Thank you very much, Susan. Thank you very much for coming this evening. It's very gratifying to see so many of you here for such a good turnout, and we hope that you'll be able to go away with some useful information. As I look at you, I can see some people I recognize. However, I don't remember all your names. Firstly, I don't remember necessarily your first name or your surname. It's one of the hardest things that we actually have to do is to remember people's names. And I think I see a number of people nodding and realizing that this is the case. So what I'm going to do is just talk a bit about MCI and try and give a definition, and so that we have a common understanding of what we're talking about. And we're just going to take 15 minutes to do that, and then Carolyn is going to take over from there. So this diagram, some of you who have been to the Aging Brain and Memory Clinic, either as someone with a memory concern or accompanying someone with a memory concern as an informant, a family caregiver, person who's concerned, will recognize this diagram. And so at the top left, we have a group of older people who we regard as being supernormal. We characterize them in that way. And these are people in their 80s who score similarly to a 20-year-old, very similar to a 20-year-old on cognitive tests. Normal cognitive aging is what most older people would regard as being normal. And these are people in their 50s, 60s, 70s, 80s, 90s who don't have any complaints of memory impairment. And when we test them on memory tests, they score on the normal range. So they don't have any complaints and they score on the normal range. People with subjective cognitive impairment are people who have the subjective complaint of memory impairment. So they think that my memory's not as good as it used to be. And so there's been a change. They notice there's been a change. And the second thing is that they're concerned. They're concerned about that change. Now, when we do the memory testing on standard memory tests, they score also in the normal range. Mild cognitive impairment are people who not only have the complaint of memory impairment, their family members may also be aware of it. In fact, it may be the family members that bring it to their attention. And when they're tested on memory testing, on the standardized measures, now I'm talking about a mini mental state or a Montreal cognitive assessment, which is the Canadian test that we do, they have some impairment on that, particularly in the memory part of that test. So they have the complaint, but they also have evidence that they actually have memory impairment. And I'll go into that definition a little bit more. Dementia, on the other hand, are people who have the memory complaint. They have evidence of memory impairment on testing, but their instrumental activities of daily living are impaired. So that's how we distinguish between each of those different groups. Now, to expand a little bit, just down at the bottom of the diagram, you'll see the sort of proportions in the Canadian population. So this is the prevalence, the number of people at any one time, or the proportion at any one time that have cognitive impairment. So at age 65 and over, you can see that 8% have dementia, and 17% have mild cognitive impairment. So combined, that's 25% have some form of cognitive impairment. Everyone 65 and over in the Canadian population, 75% have normal cognition. But if you get to 85 and over, so just look at those 85 and over in Canada today, there's 33%. So a third of people have cognitive impairment, one third have mild cognitive impairment, one third have dementia. So 2/3 together have cognitive impairment, and then 1/3, 85 and over, have no cognitive impairment. So you can see that this is a condition which is quite prevalent in older people, but particularly people in their 80s and older. So to go to the definition, there are formal criteria, and these have evolved over time, and this is one of the more recent evolutions of those criteria. So this is getting to the precise definition of what we call mild cognitive impairment, for those of you who really want that precision. So there has to be a concern regarding a change in thinking, and we call that cognition. There has to be impairment in one or more cognitive areas. And that this has to be, that little sign means more than, so more than expected for the person's age and their educational background. There's a decline in performance over time in cognitive domains. So principally it's in the memory domain. So if you do repeated Montreal cognitive assessments, which is an instrument we use in the clinic, or family physician, some of you may have been to your family physician and a nurse or the family doctor may have done that, or someone, if you've visited the Alzheimer Society, one of their memory clinics, they may have done it, and some of the family health teams have memory clinics as well. They may have done this instrument with you. And so there'll be impairment on that memory test. There may be impairment in planning. That's what we call executive function, so a person's ability to plan. Maybe attention deficits. There may be difficulty with some language. Word finding is a common thing that people have problems with. And there may be difficulty with spatial skills. Can you hear me all right at the back? You can, okay. And there may be impairment in short-term memory being the principal impairment. And this is most commonly seen in people who have mild cognitive impairment who are likely to progress to Alzheimer's disease, which is the most common form of dementia. Dementia, we refer to this often as an umbrella, a large umbrella with different causes of dementia. But the most common cause of dementia is Alzheimer's disease. About two-thirds of people have Alzheimer's disease. Another portion, maybe 20% or more, will have Alzheimer's with small strokes due to vascular dementia, and then there are rarer forms of dementia. But Alzheimer's is the most common form of dementia, either alone or in combination with a different type of dementia. Now, if we want to look at the activities of daily living, remember we said in mild cognitive impairment, people with mild cognitive impairment, there's preservation of the instrumental activities of daily living. So what do we mean by that? So if a person's still working, they're still able to work and do the normal activities that they have to do at work. At home, a very good task, which represents executive function, is cooking. Most people can cook, and there's tremendous variability how well they cook. Some are very good, and some get by. But most people know how well a person can cook, but if you think about it, it's a very important executive task. You have to be able to imagine what you want to create. You've got to know what's in the cupboard, what's in the fridge, and what you're going to have to purchase. You have to think about proportions. How many people are you going to be serving? You have to think about what are the combinations you wanted to put in this, and if you're doing the recipe off the top of the head, you'll know what spices you need to add, what duration you're going to have to cook these dishes, and you're going to want to bring them all together within a certain time frame so that they're all, if it's going to be a hot dinner, you're going to be having it all the dishes coming together at the same time, and nothing's going to be overcooked. And most family members will know if someone's cooking is off, if it's not as good as it used to be, if something's missing. So it's a very good example of an executive test. Finances, using technology is another example of activity of daily living, house work or yard work, or being able to do work, or being handy around the house. My wife says I'm not very handy, but some people are very handy and can do things. So usually these things are intact. Now, by intact we mean that they may take more time and may be less efficient at doing those things. So if they're really good at plumbing and being able to replace the washer on a tap, they would be able to do that within a certain period of time, maybe 20 minutes. Maybe if it took them half an hour or 40 minutes, that's okay. But if it's taking them half a day and they're still not fixing the problem, that is impaired. That's really clearly impaired. So these activities may be a little bit, very slightly less efficient, and we get confirmation from a family member. So with the Aging Brain and Memory Clinic, that's why we want some family member to come along and just to verify what from their perspective is going on, and whether there has been any change in the activities of daily living. So we need some evidence that there is change over time, and that's why we often do these repeated tests, this Montreal Cognitive Assessment, or MoCA. And if you want to look at the MoCA, you can go on the if you're computer savvy, go onto the internet and go to moca.org, O-R-G, and you can see what that's all about. Now, one caveat about the MOCA, if a person does a MOCA just one time and there is some impairment, and that's the first time they've ever done it, you have to be cautious about how you interpret that, because this is the first time they've ever seen it. And it's much better if there's 2 or 3 MOCAs over time, because often if a person has mild cognitive impairment, or even if they have subjective cognitive impairment, they may do better the second time or third time. But if they start to decline after that on the 4th or 5th time, then you know that something really is going on. But a person with mild cognitive impairment can pull one out of the bag and actually get better, because they say, I've done this test before, I've seen it before, and they can actually get better. So one has to be very careful about making a diagnosis just having done one memory test, particularly if it's just the first time they've seen it. So in terms of our process, the process we have through the Aging Brain and Memory Clinic, people are referred by their family physicians or a specialist or a nurse practitioner, if that's who is the health professional working with them. At the moment, we've managed to get our new appointment times down to about 4 to 5 month wait time. If it's really urgent, we can see people more quickly than that. We just need to know it's urgent, and we can look for a cancellation. There is a phone interview by a registered practical nurse prior to the clinic visit, speaks with the person with memory impairment and the caregiver to get some initial history and just to prepare them for coming to the clinic, because the assessment is 2 to 3 hours. We go through a history, a physical examination, a detailed neurologic examination. We talk to the person with the memory impairment and also with the caregiver separately, and we want to get a sense of what is the stress that the caregiver is under. And also we then discuss together the diagnosis of what the memory problem is. Is this subjective cognitive impairment? Is it MCI, mild cognitive impairment? Is it dementia? And then we will provide counselling. There are non-drug approaches to mild cognitive impairment, so aerobic exercises, a Mediterranean-style diet, socialization and mental stimulation are 4 of the things that we talk about, and maybe we're going to talk about it a bit more. A written report, a handwritten report that is given at the time of the appointment to the person, and that's then faxed to the family physician, and a typed report follows that. And then there may be a possible referral to a neuropsychologist for further clarification of the diagnosis if there's any uncertainty. And the person will be given a follow-up appointment to come back in 2 years. And one thing we're encouraging the people who have mild cognitive impairment, in that interval between the 2-year wait, is that they have a further MOCA test done by the family physician. And we're encouraging the family physicians, a lot of them have been trained how to do the MOCA or have one of their nurses to do it. We may do neuroimaging, a head CT scan if a person hasn't already had it, or even an MRI of the head, looking for white matter changes in the brain. We talk to people about research and participating in research studies, particularly investigator-initiated studies, or even some of the pharmacological company randomized controlled trials of new compounds. So this diagram represents the spectrum of cognitive decline that I had referred to earlier, and you can see that MCI is right up in the top left-hand corner again, and you can see that steep curve really represents the change over time over a number of years, and in this diagram it's representing about 9 years decline from sort of late mild cognitive impairment into early Alzheimer's disease, all the way through the different phases of dementia to sort of profound dementia. And you can see that yellow curve has really been generated by thousands of people who have been studied in a naturalistic way without any intervention. There are medications which have been approved, and they have a modest effect, and if they work ideally they would follow that blue line. So you can see the blue line, which really represents where we would start medications if a person has progressed from a mild cognitive impairment to early dementia, usually Alzheimer's disease, as I indicated earlier. They would then be started on one of the 3 drugs that we have, and so you may recognize the names: Aricept, Exelon, or Reminol. Those are the 3 compounds. Those are the drug company names. A person may go on those. There may be some modest improvement in memory, but often there's then a decline following 6 months to a year later in a parallel fashion to the course a person might have taken following that yellow line. The present research efforts are really being focused on trying to treat and prevent or slow the progression of Alzheimer's disease using disease-modifying treatments. And these treatments, if they were to work optimally, they might follow that red line. That is a theoretical line at the moment, but you can see if we had compounds, the red line is maybe a little difficult. Can you see the red line at the back there? Okay, maybe. Okay, the red line follows the green dot, and the red line goes in this direction here. So the red line is going in this direction here. So this here, so if a person, if we had a disease-modifying treatment and it was to be effective, if a person followed that red line and they were to end up there, you can see that on their mini-mental score, as represented on this vertical axis over here, the years are across the bottom here, out to 10 years here. But if they ended up here, they would be more independent than if they would be down here or down here, because as your mini-mental goes down, a person becomes more functionally dependent. They get more dependent even with their basic activities of daily living. So this is a more desirable position to be than to be here over time or here. And this is what we're really trying to do with the research that we're involved in, is how do we actually alter this curve? How do we make this a less steep curve, a more shallow curve, and how, and that may be part of the discussion tonight, how do we change this trajectory so that people may be more independent? London is very active in this research field, and I just have this one slide showing some of the initiatives. This CCNA is a consortium of Canadian centres across the country looking at all types of dementia. It's funded by the CIHR, and London is going to be leading the coordination for the cohorts of people that are going to participate in this study, 1,600 people from across the country from about 30 or 40 centres. And we're going to be involved with the coordination and training of those centres. We will be very active ourselves, and we would love if any of you wanted to participate in this study. We would be keen for you to be. So people who have SCI, MCI, any form of dementia, we would be interested in talking to see if you meet the criteria for the study. We're also involved with the Ontario Neurodegeneration Disease Research Initiative, or ONDRI. Dr. Michael Strong is the Dean of the Medical School. He is the principal investigator of this study, and there's 600 participants in that study for about 12 centres in Ontario. And so we're doing all of the neuropsychological testing for the 130 participants that have been recruited for that from London. We also are the lead centre for the gait protocol. We do very sophisticated measurement of walking on a gait mat. It's a sophisticated gait mat that can look at the way you walk and looks at not only gait speed or gait velocity, but gait variability. And one of the things that changes is if we do this under what we call dual task. So if you walk normally, and then if you ask a person to count backwards or to name animals as they walk, well, they're now doing two things. They're walking and talking, and they slow down. And so this is, we're studying this because this is predictive of who might progress to dementia. We're also got a lot of strong collaborations with the neuroimaging sites in London. So we have some remarkable expertise at the Robarts Research Institute with the MR spectroscopy, and this is with 3 Tesla and 7 Tesla scans. And at St. Joseph's we have the only, so in Canada we have the only 7 Tesla scanner here, so this is a very strong magnet being able to look at the brain in very special ways, and we have some important projects that we're doing there, and so we're keen if anyone wants to participate in these studies. These are non-intervention observational studies. And then PET scans. We have the only PET MRI scanner in the country at St. Joseph's Healthcare, and we've also got a number of studies going on there. So we're keen for people to be able to be involved with those studies. We also have a large number of pharmaceutical trials that we're also doing, looking for these with compounds that may be disease modifying. So I'm going to stop there, and I think Carolyn, you're going to take on